typically what we find in the US, the entire bowel prep score is everything automated, where you just fill in the number. So what is the bowel prep score? The Boston bowel prep score, as Dr. Kiesel and Dr. Nayantara was also showing earlier this morning, what we call as BBPS. How do you kind of assess the quality of colonoscopy in terms of preparation? In the Boston bowel prep score, what we do is that we give a scoring rank of 3, 3, and 3, which is essentially saying that, 3 for the left colon, 3 for the transverse colon, and 3 for the right colon. So 3 plus 3 plus 3 is 9. If a patient's prep is 9, is absolutely superb. That's what we would like to see at the end of the day. But anything above 6 is accepted. 2 plus 2 plus 2, 6 is accepted. Now, if you have a colonoscopy, somebody comes with this, obviously, this patient would qualify as 1 in the ranking. Okay. So the best prep is 3. This patient gets 3 score. This patient gets 2 score. And this patient gets 1 score. Essentially, all the ones come for a repeat colonoscopy, and 2 depends upon the performer operator in terms of the decision making, how soon he has to come, or whether he's going to follow the same surveillance interval in terms of rescheduling his colonoscopy. So we talked about fecal intubation rate, bowel preparation, and the third important quality measure is your withdrawal time. So the cecal withdrawal time is also very important, and we want to show you the data here that as typically it should be more than 6 minutes. So in our series, what we found was that in the primary CRCS, and we had greater than 6 minutes. So which was less than 6 minutes, you can see the bar about 14%, and greater than 6 minutes was 83%. In secondary CRCS, it was 86%, and 11% was was greater than 6 minutes. So majority of patients, if you look at it, was certainly more than 6 minutes. The other we talked about this slide, the gender distribution of polyps. Now let's look at what is the polyp distribution in a population, both in primary and secondary. So if you look at all polyps, all comers together, there's 49% men had polyps who came for primary CRCS, and then 34% women. Then in secondary CRCS, 49% were identified to have polyps, and 40% were women. Now, if you look at the histopathology in the polyp distribution, we also looked into this very carefully. We have a system where once the polyps are removed and the pathology releases a report, it is also logged into the log register, apart from being entered into the doctor's clinical records. So we looked at, the histopathology of these polyps, and I could see that polyps are classified into inflammatory, hyperplastic, serrated, villus, and tubulovillus, tubular adenocarcinoma. So, these are all inflammatory polyps here, what we are seeing. The traditional adenomas, they're all grouped in the red. So you could see that age stratification, we have kind of broken down to 5-year aliquots in terms of the age. So the highest age distribution of adenomatous polyps were from age 60 down to age 80, 85. So the highest being, certainly 70 and 70, those are from 70 and 80. The same thing I find in the US. If somebody did not follow the recommendations to have a screening colonoscopy at age 45 or 50, they're coming late, you're guaranteed to find polyps in these patients, and almost 60 to 70% of them, because they did not do their earlier screening. So this is our data in terms of histopathology of polyps, and I want to show you. Now this is the distribution in men, and then as you could see that it is interesting. Now you might be already thinking the ADR is 30% or 35%. Now where is continental at? So in men, our adenoma rates across different age groups were 30 to 43, and we'll just show you the blended rate, blended average. Here is the serrated adenoma. We had a very low incident of serrated adenoma. There was only a couple 2 cases for the entire study. probably this could be, of course, our pathologists in India, pathologists, this is all a new game for them. They're also having a learning curve. It could be that we missed or misclassified, or maybe we have a very low incidence of, serrated adenomas or traditional serrated adenomas at the end of the day. I'm not sure about it, but that's what we have seen. So this is again, I think why is it double clicking coming the same thing, Babu? Okay, so this is again the polyp distribution in women. So women, we show decreased polyp distribution when compared to men. You'll see in the previous graph that these are much lesser, and it goes along again with all the international publications, the highest being in the age group of 75 to 79. So the histopathology of polyps, I don't have to go into details. I'm not a pathologist, but at least I know what is a hyperplastic polyp. At the end of the day, you have the hyperplastic polyp. This is your tubular adenoma, and this is a villus adenoma. In hyperplastic polyp, you don't see any atypical nuclei. Here, the elongated crypts and the epithelial surface. You have atypical nuclei. This is the high power magnification, that you can further study how nicely these elongated crypts are. And with the presence of atypical nuclei, the pathologist declares this is a tubular adenoma. And this is all the villus pattern or the trabecular pattern, that you see for villus adenomas or tubular villus adenomas. So this is the histopathology of serrated polyps again, for just to show you. This is a traditional serrated polyp, and this is a sessile serrated polyp. And this is in comparison to a tubular villus adenoma, and this is the normal colonic biopsy. So the normal colon biopsy, then if you look at the polyp architecture, this is all changed. So this is a tubular adenoma. I'm just trying to show you here how does a serrated adenoma looks when compared to a tubular or a villus adenoma. So it's very important to have good pathologists, because we have seen at the beginning of this journey at continental hospitals, and the touch and feel of everything after 40 years of experience, when you're removing a polyp, you're almost 100% sure this should be an adenoma. When our pathologist report is hyperplastic polyp, when Dr. Snigdha is sitting here, they do a wonderful job. I just said, no, I don't accept this. No, I'm not accepting this. And then we said that let's send for a second opinion. So we have gone through all those motions. I think they're over the learning curve. They understand every day. There's so many specimens are going on. We have great confidence now in the reporting ability in terms of the various classification of the histopathology of polyps. So the adenoma detection rate, okay, the climax at the end of the day. This is what it is, what we have. So in primary CRCS, the ADR, the overall ADR rate was 28% and 19% for women. In secondary CRCS, 31 and 21, and the overall CRCS was 30% in men and 20% when we compare primary and secondary. Is my time up? Is my time up? Okay, I'm almost done. So yeah, why don't you operate it? There's something wrong with that. I'm very sorry. So when you look at the age stratification of the ADR, yes, age stratification in men and women. Okay, we already talked about. Go to the next slide. Yeah. So age stratification again in secondary CRCS, we just touched based on that. Next slide. Now, serrated polyp detection rate, I already confessed, it's a very low incidence. We just had about a couple polyps or 3 polyps overall in our study of 2,000 patients. Next slide. So here's a comparative data of ADR to the US and the continental hospitals. Okay, this is the overall ADR for the United States, which is 37%. And we are at 25% here. But when you look at the ADR of men, we are pretty much comparable. And it was 44% what is reported recently, and 30% here in men, and in women, 31 and 20%. Now remember, the US studies are hundreds of thousands of patients. We have a very small sample of 2,200. I'm extremely confident that, what is this telling me at the end of the day? As I was just discussing in the corridors to John and several of the other faculty members, many times we say in India, this only happens in the West. We don't have it. That we don't have nonsense, which I've discussed, I'm sorry to say, ever since my journey here. I am finding almost for all gastrointestinal diseases, there's a parallelity at the end of the day. Unfortunately, we have not done studies. If you have done, they are suboptimal. We have enough data. We have enough data, more data probably from the Western Europe put together. So I think we need to go ahead and take this extremely seriously for us to put this data together to only help our own population. What are the best methods that we can adopt? And we might come out with our own guidelines at the end of the day in terms of screening or preventing cancer. Next slide. But your thumb is also stuck. Why can't we have another this thing? Can you all stand up and see anybody feeling the pain here? Oh, this is compared to the Europe and China. We had some articles to compare to. It's very interesting, China. I don't know how they're doing it. As John was telling something about China the other day about their data. So this is also on the polyp there, John. I can give this slide to you. So the Chinese data is just 17% what they reported overall. But when compared to Europe, we are pretty much there, 31, 30%, and for women, 20 and 24%. So I just wanted to do both the US and European comparison, but China is publishing prolific data at the end of the day. We thought, next slide, let's go ahead and also use that. So what is the significance of ADR for different indications? And do ADRs calculated have comparable associations with post-colonoscopy colorectal cancer incidence? And overall, with ADR using all colonoscopies, whether using a screening ADR or a diagnostic ADR or only screening versus diagnostic or surveillance ADR, does that make a difference? This is the question that is being asked. There's a great article by Jensen and Corley and Jeffrey Lee as an editorial comment who just made up a few weeks ago. Can you please show that? So here we show, irrespective of in what group that you're doing, this is the latest publication. Overall ADR in this study reported 36. If you're screening, it's 29. If you're diagnostic, it's 37. If it's surveillance, it's 48. So the question is, do you really need to break down and call and only monitor as screening ADR is a question we're asking. Now, academicians are questioning, is just screening ADR enough, or we are avoiding all these other patients with lack of good history and whatnot? I think the future next 1 to 2 years, we should be able to see that. Next slide is just the same representation. Next slide, let's go there. Okay, now last couple of slides. What are the measures that increase adenoma detection, especially for residents here? Certainly, your colonoscopies should have a high definition. Artificial intelligence, which is now coming, we have used the GI technique and things of that nature in the US. They certainly increase the yield of your polyps. The issue about using chromoendoscopy, methylene blue, and narrowband imaging certainly has a role. And Dr. Santosh is sitting in the audience. Maybe I could call him the father of NBI of Hyderabad. He always, about any case and whatnot, he switches the NBI button. There's a blue light imaging, which is from Fujinon. And then all these other things make a difference because the colon has, tremendous number of folds. And it's very easy to miss if you're quickly withdrawing, if it's not properly prepped. And so how do we really optimize when, during the folds? So the GI balloon, the distal attachment cap or hood, we also use that in the US. All of these things are shown to increase, but a little more cumbersome. It delays the time. Instead of 6 or 10 minutes, it's go to 40 to 50 minutes. So are we going to adopt this technology, or are we going to wait for a better artificial intelligence device that's going to help us keeping the time of 6 to 10 minutes and still we are able to harvest polyps in the patient? That's what I think we're heading on in terms of research. Next slide. The best practices, we just highlighted. I don't want to go through this, but basically make sure that the colon prep instructions are given well by the nurse or the PA, and that's what we do. We thoroughly give it. We give it an instruction sheet, just like in the US. We call them the day before. We go over the prep instructions, especially with the split prep, what time they need to wake up, take the first phase of the prep? When do they have to wake up? Second phase of the prep? All of these things are important. If a patient comes a bad prep, it's not only loss to the patient, loss to the endoscopist, and we're not making a diagnosis and having them do it again. Okay, so last couple slides. I forgot to get a selfie during the procedure. Can we do it again? Certainly, if the patient's colon prep is bad, you can tell them, we'll take you down because you missed a selfie. Having a colonoscopy is the only time when what and hyphen would be considered a compliment. Thank you so much. Appreciate it.